Right now.
Yeah.
Good
Uh,
morning, everyone. For those of you who I feel like I know many of you on this call, some of you I don't. Just as a quick introduction, I'm Lauren Lyman. I'm the Executive Director of BLOODPAC. For those of you who found us somehow, which is wonderful, and want to know a little bit about BLOODPAC, we'll give a quick introduction. BLOODPAC was founded about 8.5 years ago as a commitment to the initial cancer moonshot, working to accelerate the development, the approval, and the accessibility of liquid biopsy technology for cancer patient benefit. We have not veered outside of that mission. We are very narrowly focused and work hard to maintain that path. We are interesting in that we work in working groups where we have about 10 of them at any given point in time. And there are co-chairs that run those working groups that are aiming at providing deliverables to the larger liquid biopsy community. The call you're on today, the seminar we are on, is part of our multi-cancer early detection and screening working group. Our co-chairs are in the upper left-hand corner of my screen. I don't know where they are for you. Christina Clark-Durr and Bree Mitchell. We are, in a moment, Bree is going to talk to you a little bit about the working group itself, what the deliverable is they are focusing on now and the input we're looking for during this call and how you guys can be helpful, and hopefully what we're aiming to get across. And then Tina is going to help moderate the conversation and keep us moving. We have three wonderful individuals, all who have participated in BLOODPAC over in the past and ongoing. Dr. Peter Sasieni, who will be giving a presentation. Peter, we working on our slides? We good? Yes, there we go.
yeah,
All
that
right.
worked.
Awesome. We are so money here. Donna Roscoe and Jody Hoyos, who are going to be joining in a little bit as part of our panel conversation after that. Again, for those of you who didn't hear it first, you have been given the power to unmute yourself. Do not do that unless there's a specific question asked of you, or I will have to mute everyone. So just unmute yourself if you are going to be part of the panel or if there's something urgent that we need to say. If you would like, we do encourage you to put questions into the chat throughout the conversation. We will be monitoring it and watching it. We do have several questions that have already been planned and asked. They will help us generate the content we need to move the working group forward towards the end, but we should have time for one or two additional questions. Anyone right now, you're given permission to unmute yourself. Anyone have a question right now that they want to ask? Amazing, amazing. And with that, Bree, I will turn it over to you to discuss and introduce the working group and Peter.
It's actually going to be Tina. Hi,
Tina,
everybody.
sorry guys.
I'm Tina Clark-Durr. I am VP of Epidemiology at Grail, and I serve with Bree Mitchell of Natera as co-chair of BLOODPAC's Early Detection and Screening Working Group. And I just wanted to give those of you who might not know about our working group and what we're up to a little bit of background about our work. So the goal of our working group is to develop and build consensus around common definitions, terminology, lexicon, and standard frameworks for clinical validation of blood-based early detection, cancer early detection tests. And we all know this field is absolutely exploding at the moment. And what's happening is that we are moving so fast that we are not using the same words for the same concepts, and we're using different words for the same concepts, and it's confusing the field. So we're trying to come together to align on the performance words, words like sensitivity, specificity. What do those mean in a world where we have single cancer early detection tests? We have multi-cancer early detection tests that are only targeting several specific cancers, and we have tests like Gallery, which are more pan MCED tests. You can tell very quickly if we don't all get on the same page, we're going to confuse regulators, doctors, and patients. So today, we're super excited to have brought together a bunch of folks in the field who are talking and thinking about this. Peter Sasieni is professor of cancer epidemiology and joint lead of the Center for Cancer Screening, Prevention, and Early Diagnosis at Queen Mary in London. He's also PI of the NHS Gallery study. Donna Roscoe is a consultant and former acting director of DMGP at CDRH at the FDA, and Jody Hoyos is CEO of the Prevent Cancer Foundation. So we're super excited today to have Peter present his talk, Performance with Purpose, Metrics that Perform Clinical and Public Health Decisions, and then we'll have some panel discussion about what he presents. And thank you everybody for joining today. And with that, Peter, take it away.
Thank you very much, Tina and Lauren, giving me the opportunity to share my current thinking about performance metrics and what we should be focusing on when thinking about multi-cancer screening. As a way of background, I have a PhD in biostatistics from the University of Washington and have been a cancer screening researcher in the UK ever since. In terms of disclosures, I'm a scientific advisor to GRAIL, and I have grant and research support for NHS Gallery from GRAIL, and also a consultant for Median Technologies. So key to thinking about how to characterize cancer screening tests is the realization that screening is fundamentally different from diagnostic testing. Of course, they are similar, but by focusing on the similarities rather than the differences, I maintain that we have done screening a disservice. Why do I say that screening is not the same as diagnostic testing? Well, firstly, and perhaps most importantly, because in studies of diagnostic testing, by the end of the study, we know the true disease status of everyone in the study. That is simply impossible with screening studies. It is unethical to carry out a definitive diagnostic test on everyone, including those with only negative screens, in a cancer screening study. Secondly, because we are trying to identify disease before it is symptomatic, the usual simplification of a binary truth, disease present or disease absent, is not applicable. As cancers grow, they become easier to detect. A 1 millimeter cancer is unlikely to cause symptoms, and it is unlikely to be visible with imaging. Especially for multi-cancer tests, there are different types of cancer, and one test may be better at detecting one sort of cancer, whereas another test is better at a different cancer. Even with traditional single-site cancer tests, the ability to detect different types of cancer may vary. Cervical screening is better at preventing squamous cell carcinoma than adenocarcinoma. The capsule sponge can detect precursors of esophageal adenocarcinoma, but is less good at detecting squamous cell carcinoma of the esophagus. And thirdly, a diagnostic test only needs to predict what is present now. It does not need to predict what may happen in the future. But a screening test is aiming to diagnose cancers earlier, when it can be more easily treated, but finding cancer before they become symptomatic. A potential screening test that finds symptomatic cancers but is useless prior to symptom onset has little to offer. Because diagnostic tests are performed in those for whom there is already a substantial pretest probability of disease, they need to be able to both rule in and rule out disease. After testing, every patient should know whether or not they have cancer. Ideally, a diagnostic test should be perfect. Most screening tests simply aim to rule in disease by identifying a group for whom further investigation or diagnostic testing is justified. A screening test does not need to be perfect. It simply needs to be able to select a subgroup for whom further testing is worthwhile. Occasionally, particularly where there's already a reasonable screening test, but one that is perhaps expensive or invasive, one may want an affordable rule-out screening test as a first screen. The idea might be to find 20% of the population with 95% of the disease. In that way, one only needs to use the expensive test on a fifth of the population. Screening can be thought of as a sieve. We start with a large population of asymptomatic individuals and sieve them to try and find the few with cancer. It is a bit like panning for gold. In some definitions of medical screening, the aim is to identify individuals at sufficient risk of a specific disorder to warrant further investigation. Note that screening does not aim to diagnose disease, but simply to find those for whom further investigation is warranted. Thus, it may be helpful to think of screening as a series of sieves. At each stage, the idea is to find a smaller group at higher risk. Consider how we might apply a sieve analogy to fecal immunochemical testing. In symptomatic populations, we might refer anyone with any detectable heme. The idea is that those with no detectable heme are extremely unlikely to have colorectal cancer. We're not talking about Lynch patients here. Thus, FIT can be used to rule out cancer. But low levels of heme in feces are common in the general population, particularly at older ages. So at a very low threshold, FIT is not particularly useful as a screening test. Instead, for screening, we set a rather higher threshold, very high in England, but less high in other countries, and refer those with a level above the threshold for further investigation. FIT is used to rule in cancer in those not seeking medical help. It is used to identify those for whom colonoscopy is justified. Note too that FIT is not particularly useful as a diagnostic test. There is no threshold that will accurately identify both those with cancer and only those with cancer. The sieve analogy suggests that what we are interested in is to determine clinical validity is the likelihood ratio. Mostly for screening, we are interested in positive likelihood ratio. It is defined in terms of sensitivity and specificity. But the reason we are interested in the positive likelihood ratio is that it's the ratio between the odds of disease in those who test positive and the odds in everyone tested. In other words, it measures how well the sieve has enriched the population for disease. For those of you who like ROC curves, the positive likelihood ratio is the slope of the line joining the origin to the cut point on the curve. So it's the green line in this figure. Occasionally, we want a screening test that rules out disease. One might think of it as a pre-screening test. The idea here is that anyone who tests negative has extremely low risk of disease. HPV testing and cervical screening works in this way. If the screening test is non-invasive and cheap, then removing 3/4 of the population because their risk is tiny, and only having to use the expensive test or invasive screening on the other 25% makes sense. And that's the red line in this curve. The validity of a test in this setting is determined by its negative likelihood ratio. So traditional test performance metrics were developed for diagnostic tests, but things are rather more complicated for screening tests. If we don't know for certain who doesn't have cancer, we can't really estimate the sensitivity. In a prospective study of screening, we can't do a full diagnostic workup of everyone who tests negative on the screening test, so we don't know how many cancers have been missed. Typically, we measure sensitivity in a case series. That is, we test patients who have just been diagnosed with cancer before treatment is initiated. But that tells us about the sensitivity to cancers at the time of diagnosis. It does not necessarily relate to sensitivity to asymptomatic, undiagnosed, prevalent cancer. Sometimes we estimate sensitivity prospectively by counting all screen-detected cancers and all cancers that are diagnosed over the subsequent X months. But often X is 12, but that is arbitrary. If X is too short, we will overestimate the sensitivity because some cancers present at the time of screening will not have been diagnosed symptomatically by time X. If X is too long, we will underestimate sensitivity because we will include cancers which have only developed since the time of screening. So there's no ethical way to estimate sensitivity of a screening test to undiagnosed prevalent cancers. Instead, we need to accept that we are either going to estimate the sensitivity to cancers diagnosed routinely or to cancers that will be diagnosed over the next 12 months, say. Or we can give up on sensitivity and focus on something that we can estimate. Even if we agree on what substitute definitions of sensitivity used, it is often population dependent. For instance, sensitivity typically increases with tumor volume. Whether the test is imaging or tumor-derived biomarker, the ability to detect cancer will likely increase as the cancer grows. Sensitivity is also likely to improve with cancer stage. Many tests can be shown to have excellent sensitivity to stage 4 cancer and poor sensitivity to stage 1 cancer. Cervical screening works better for squamous cell carcinoma than adenocarcinoma. And the Gallery test seems to have much better sensitivity for triple-negative stage 2 breast cancers than for other stage 2 breast cancers. Since sensitivity is not invariant with different types of disease, the general classification of disease or no disease is not helpful. With breast cancer, for instance, do we really want this sensitivity to 2mm tumors? Mammography probably has minimal sensitivity to cancer, 100% sensitivity to very low. Performance in the population. Sensitivity is likely to be different in women than in men in Europe, North America, China, or India, and in current smokers compared to never smokers, because the relative proportions of different cancers. We showed, for instance, that the mix of cancers in Nairobi varied by the tribe. The Kamba had higher risks of melanoma, Kaposi sarcoma, liver and cervical cancer, and lower risks of esophageal cancer, stomach cancer, endometrial cancer, and nervous system cancers. Luo and Luhia had much higher odds of Kaposi sarcoma and Burkitt's lymphoma. Early diagnosis research also considers symptoms. Ovarian cancer used to be called the silent killer. Then Goff developed a symptom index that had a sensitivity of 80% for advanced cancer and 57% for early stage cancer. We confirmed the excellent sensitivity of Goff's index at the time of diagnosis, but we showed that it was less than half as good 3 months prior to diagnosis and no better than a coin toss 5 months before diagnosis, 6 months before diagnosis. A similar issue exists with pancreatic cancer. There was a lot of excitement about a recent paper using AI on clinical records to predict pancreatic cancer. The model had an area under the curve of 0.88, but much of that could be achieved using age and sex alone. When you look at the key contributors to the model, they were things like jaundice, acute pancreatitis, and abdominal and pelvic pain. There's nothing to be gained by a test that simply refers patients that any doctor would already be referring based on their symptoms. Just because a test can be used to accurately classify patients at the time of diagnosis does not mean that it is any good as a screening test. We've seen that sensitivity is likely to be different in different populations, but what about specificity? For many tests, the false positives will become more common with age. That is certainly true for tests based on cell-free DNA for FIT. For tests targeting the precursor, such as HPV testing, the probability of a clinical false positive result will be roughly proportional to the underlying cancer instance. Many biomarker-based tests are more likely to result in a false positive in individuals with underlying risk factors for cancer. Why does the lack of invariance to specificity matter? Well, the FDA says that you can calculate PPV and MPV of a test based on its sensitivity, specificity, and prevalence of disease in the target population. But that assumes that sensitivity and specificity are constant, and we have shown that they are not. The consequence is that it is very dangerous to try and estimate the PPV in different populations by assuming constant specificity and plugging in the prevalence. Indeed, if the probability of a false positive is proportional to the prevalence, then it is the PPV that will be approximately constant in different populations. So what is the way forward? First of all, we need to think about standardization. Given that the sensitivity and specificity are not constants, we need to standardize them in order to have a standard measure of test performance. What would the metric be if the test was performed in a standard population? It's a little bit like using age standardized rates or an overall cancer survival metric that standardizes to the mixture of cancer types. Here we used a weighted analysis to standardize the performance of an AI classifier of low-dose CT scans to see how it would perform on a standardized screening population, such as in NLST or Nelson trial. The key things that we needed to standardize on were the nodule size and whether or not the lesion was spiculated. As you can see, the impact of standardization was to decrease the sensitivity because the study had more easy to detect cancers, and to increase the specificity because this study had a lot of benign lesions that were difficult to differentiate from cancer. So what are we missing? Standardization is important, but there are new metrics that we should be, are the new metrics we should be using. Is there something that's completely missing? I think we need to think about how to measure how many people benefit from screening. From a utility perspective, it's important to think about the diagnostic yield, sometimes called the detection rate. That is the number of cancers diagnosed per 1,000 screens. Or we can use the reciprocal, the number of screens one needs to do to diagnose one cancer. People will argue that the diagnostic yield will vary depending on the underlying prevalence. Of course it will, but that helps to emphasize that what is appropriate for one population will be inappropriate for another. I'm a strong supporter of LDCT lung cancer screening, but I would never recommend it to a 30-year-old never smoker. Yield also helps to put MCDs and single cancer tests on a level playing field. A test detecting 20% of all early stage cancers is likely to have greater benefit than one that detects 80% of a single cancer type. Rather than using sensitivity and specificity, which tell you about the test result, given the underlying disease, we should switch things around and focus on the post-test probabilities. We can easily observe the PPV of a screening test because everyone with a positive test is referred for further investigation. For negative tests, we need to follow participants over time. We should monitor the cumulative risk of cancer following a negative screen. It does not matter if some of those cancers are screen detected on the next screen. What we want to know is how long a screening interval is safe. For how long is the risk of cancer low? This classic figure justifies the extended screening interval used with HPV testing. The cumulative incidence of CIN 3 or worse 6 years after a negative HPV test is less than the incidence 2 years after a negative cervical cytology. Pathfinder was a prospective trial of a multi-cancer screening test, measuring incidence in terms of the proportion of cancers diagnosed within 12 months of screening that were screen detected. The study had just 30% sensitivity, but many of the missed cancers were screen detected by mammography, PSA testing, or colonoscopy. If we looked at advanced stage cancers, 42% of the prevalent screen detected cancers were stage 3 or worse, compared to just 14% of the interval cancers. Note that this is the opposite of what one might expect if there was considerable overdiagnosis or a very long lead time. In that case, more of the screen detected cancers would be early stage. So I think we should be reporting diagnostic yield and PPV and MPV. Note that for both yield and positive predictive value, I think it would be justifiable to restrict to screen-detected actionable cancers, by which I mean ones that are treated with curative intent. and have suggested that NPV should be looked at over a 2-year period. But what I want to emphasize is the similarity between diagnostic yield and PPV. Diagnostic yield is just the PPV of the decision to be screened. It answers the question, if I go for screening, how likely am I to benefit? And PPV is just the diagnostic yield of the referral following a positive screen. It answers the question, if I go for diagnostic workup, how likely am I to benefit? And NPV answers the question, how safe am I after a negative screen? If yield and PPV are both probabilities of having cancer diagnosed applied at different points in the sifting process, then we can think about the magnitude of risks that justifies the invasiveness of the sieve. This table is my off-the-cuff proposal. You may argue about the exact percentages, but I hope the ordering is less controversial. In all cases, I'm assuming the test is clinically valid in the sense that its positive likelihood ratio is at least 5 and possibly over 20. I'm suggesting that non-invasive tests such as a blood test or a urine test could be done so long as they pick up at least one cancer for every 1,000 screens. A low-dose CT scan, because of the radiation exposure, I would require a diagnostic yield of at least 3%. Before doing surgery, I'd want to be at least 30% sure that I would find a cancer. In summary, to establish clinical validity of an MCED test, I would like an overall positive likelihood ratio of at least 10 and a site-specific ratios of at least 5. Additionally, I'd like a diagnostic yield of at least 1 per 1,000 in the intended population, and an overall PPV of at least 7.5%, with site-specific PPVs of at least 3%. Thank you very much.
Thank you so much, Peter. That was fantastic. Really appreciate the comments. I wanted to remind folks that if you do have questions, please put them in the chat. Even if we don't get to your questions, it will be helpful for us to know what questions there are in the community so that we can continue to work toward answering those questions and addressing confusion. So at this point, we'd love to open it up for our panel, Peter, Jody, and Donna, to kind of share their thoughts on this topic. And we have a few questions prepared. And again, we'll try and answer questions from the chat as we have time. So I think, you know, as Tina mentioned, one of the key things we're trying to do in our working group is understand what the kind of key elements are that are confusing to stakeholders, and then help to address that and provide the context needed for those stakeholders to understand how these tests are going to impact them. So for each of the panelists here, we'd love to first hear kind of what are the 3 most important elements that need to be communicated to your stakeholders to help them interpret the new MCED test study data. And Jody, I can see you first, so I will let you go first.
Laughing at the many thoughts I have. Thank you, Bree. Peter, that was great. I really appreciated your presentation. I particularly liked your little definitions when you have your summary of metrics, the layman's language that you use in the definitions of positive predictive value and yield. That's really the way we want to be communicating with patients, because none of the terms and lexicon we all work so hard on standardizing is going to be effective in the general patient population. We need to be transparent about it, but it is not the way they're thinking about it. And I'll just share a couple of things from the data we have from our early detection survey, because fundamentally people want to know, does this work? And they're going to want to know from their provider with a yes or no. Sensitivity, specificity is not where they're going to go. Can I get it? Will it be paid for? What will it feel like? So, and am I going to be okay? How often do I need to get it? The data we have when we survey across the United States for how people's perceptions and behaviors around cancer screening is about 73% of people express fear with getting a cancer screening. Of course, the highest reason behind that is the fear of getting a cancer diagnosis after diagnosis, so not screening, but is this going to lead to a cancer diagnosis? Do I have cancer? But the biggest factors right beneath that are worried they will experience pain or discomfort during the screening. That's 26% of people. Worry about they will feel awkward. This is particularly true in different populations, LGBTQ communities, Black communities, Asian communities. Worry about unexpected costs, and worry they will receive a false positive result. Sharing that to say, when we think about performance metrics and communicating with people, we have to also include what is completely foreign to us when we're thinking about this scientifically, which is what will it take to drive people to get these screenings and want to have them? Because to Peter's point, when he said, measure how many people will benefit. Well, none if they're not willing to take it. So how do we include what we know are consumer preferences into our performance metrics as we develop? That's it.
Thanks, Jody. Donna, do you want to share your thoughts?
Well, I would just add to what Jody said, which is that precise, concise, and transparent statistical methods and information about the performance of the test is obviously very important. Per cancer is still very important because it informs for each patient. You have to remember that a lot of the times I think these discussions are population-based because they get to reimbursement and the larger global market, but these tests are implemented at a patient level, and so population-based reporting might not be relevant to that population of that particular physician and the needs of that particular patient population, whether they're older, whether they're high risk, and what the risks of those particular patients are. So again, I agree with Jody, transparent, clear, informative statistics, as well as per cancer reporting, and then information about the stage. Some of this information could be clearly presented as a graph so that everyone is on the same place. And also, I think something though that wasn't mentioned was clear information about how this test is implemented in a clinical workflow, the value it has over or not as valuable as other testing, how it should be implemented when different results are found. I think that's a really clear, important metric to be reported.
That's awesome. That's super helpful. We've talked a lot about context and how context is important for these statistics. I thought, Peter, it was really interesting how you brought up the geographic differences and how that is something that I think we rarely think of. And so I think that's an interesting context for us to contemplate as community as well. Kind of building off of this, and Peter, I'd love your thoughts on this too. What terminology has been the top source of confusion for your communities with regards to kind of clinical validation statistics? And do you have any suggestions for BLOODPAC and our working group for how we can help create a framework to alleviate that confusion?
I would love to start off on
Go
this.
for it.
Because I do know that sensitivity and specificity is probably one of the largest sources of confusion for a test like this, because we also saw that in the prenatal space. It really provides false confidence in the test reporting. And a lot of physicians, and certainly not patients, do not understand the value of PPV and NPV in diseases that have the low prevalence, which Peter did an excellent job of discussing and presenting the relevance of. So I think the value of sensitivity and specificity for a test like this is very confusing. I'd also add that a lot of these studies are done with case controls, and I think there's a lot of confusion around the value of case control studies, which Peter also addressed in terms of not really being representative of the target population and inflating the performance. And a third thing that I would say is a lot of source of confusion is the definition of risk. So certainly in these studies, there's discussions about high risk. And what is high risk? Are you talking about symptomatic or asymptomatic patients? And how is that relevant on a per cancer basis? So I think the definition and discussion around these tests and their value in patients who are symptomatic or asymptomatic, having high risk, is really something that's really misunderstood as well.
Thank you. Yeah, and just as a plug for our working group, we did have a lot of discussions about that, had a AACR session last year, and a white paper that came out, I think in April, talking about risk and how that term is really confusing. So appreciate you bringing that up in particular. Jody, do you have any specific things you want to add from your stakeholder perspective?
Agree with Donna's perspectives, and sensitivity and specificity being the top two challenge in nearly every conversation that I'm on. I also want to highlight an additional consideration for this group in particular is the still frequent use of putting multi-cancer tests or blood-based screening tests in the diagnostic category. So we've all been on panels where you're talking about the innovations in diagnostic testing, and this is not, to Peter's point. And I think it's very confusing for patients who think that a screening test is a diagnostic test, and that a genetic test is a diagnostic test. I mean, we just haven't done a good job of differentiating between screening and diagnosis.
Peter, it looked like you had a comment as well.
Yeah, so I think, I mean, my bugbear is false positive rates, because first of all, they're not rates, they're proportions. And secondly, I don't think anyone knows what the denominator is meant to be. And you see a lot of confusions with people getting mixed up. Is this to do with the 1 minus the positive predictive value, or 1 minus the negative predictive value, or what's going on there, or 1 minus the specificity? So I think also the focus on probabilities rather than thinking about expectations is probably not serving us well. So the expectation is the sort of the probability of the event times the magnitude of the event, and we talk about risks and of different sort of events as if they're all equal, or that the harm is equally harmful as the benefit of not dying from the cancer. So I think we need to make sure that we have a way of putting these things in perspective. And then I think that the most people, including myself, are very bad at interpreting small risks and really knowing what it's mean. And you've got all the behavioral economics work of and sort of prospect theory of Carnahan and Tversky, that even if you tell people, they're not rationally able to process those risks in a sensible way. And so I think we have to be quite careful about what we're presenting to people. And there's a lot of work that you can suddenly multiply the harms by tenfold, and it doesn't make people change their mind, or you can reduce them hugely. So people who are worried about the harms are worried about the harms, and people who aren't. And so actually the quantification of some of these things are not nearly as important to the general population as they are to researchers. And I think that's worth thinking about.
Thank you all. Those are really, really insightful comments. Any thoughts about how BLOODPAC in particular might help address this? That would be any of these confusions that we aren't already doing?
I'll jump in. I think BLOODPAC could be hugely beneficial by working with all the stakeholders, especially people in the clinical community in the front lines with these patients and their real-world experience on some of the management of these patients, to generate physician labeling that translates the statistics into diagrams. I think that people are very responsive when they have data in a visual format. And, graphs of the PPV as a function of the stage, or graphs, so that the range of PPVs can be used to inform the physician about, the likelihood of the results and the value of the results on a per cancer basis. I think that BloodPAC is in the unique position to offer a lot of opportunity to beta test, or the comprehension of these types of information sources.
Well, I guess in kind of the same vein of what we've been talking about, and I think even Donna, you mentioned, people are confused when there's a case control versus a different kind of study design. One of the issues that we have noted is that, people want to compare tests and they want to consolidate things into a nice, neat table across different assays. But usually we're not comparing apples to apples, it's apples to oranges and pears. And so, I'd love to hear if you have thoughts of how do we help shift that paradigm so people aren't comparing things that aren't actually comparable.
Personally, I think that's why the granularity is important. I mean, I can't speak for FDA, but I do know that FDA is very interested and motivated to understand the more granular performance of these assays. So when you're wanting to actually speak apples to apples, you need to get more granular. The diagnostic yield is a really interesting metric and a valuable metric, certainly for in many venues, but ultimately you are going to need to be able to understand that the denominator, as Peter discussed, on a diagnostic yield is heavily influenced by a number of factors. And so the only way you could actually be able to compare test to test is by understanding the more granular aspects.
I agree, but I think that I don't agree with Donna about the fundamental importance of looking at each cancer type separately. The whole point of multi-cancer tests is that you're going a single test, you go to screening once, and it's going to find cancers at all different sites, lots of different sites. And if you have one site where the sensitivity is only 10%, it may still save a few people's lives, and it comes for free because it's part of the same test. And what the point of pointing out to people is that it's not very good at that, unless you've got an alternative screen. And then it makes sense to say, no, this is only complementary. You still need to have your breast screening, you still need to have your lung screening, you still need to have your bowel screening. It's not intended to replace those. But generally, people are at risk of lots and lots of cancers. Most people there are very few people in the world who are extremely low risk of getting any sort of cancer. So is cancer screening useful for them? Probably yes. And if you're finding lots of different types of cancer, it does become important in the detail to start looking at it, but having to label it to tell you, oh no, this is the different sensitivity for different cancers, I don't think makes very much sense. And it sort of misses the point of trying to move beyond single cancer testing, which means you're never going to have a screening test for a rare cancer, to being able to do something where you can actually find a common signal to a variety of rare cancers. And so I think there's a danger of sort of throwing out the baby with the bathwater if we keep focusing on the need to look at every cancer type separately.
Yeah,
I
it's
don't know.
interesting. It's sorry. I can see both perspectives but I do think that there's that need for the labeling and the really in-depth information by cancer type will be important in these early years for trust building. Right now, we don't have an environment in which the test builders are trusted navigators for public health. And so I don't know how you'd overcome that need to be very transparent about all the performance, with the understanding is people will use that information to undercut the value of the tests. But that's where I go back to why that patient perspective and what they have been telling us for decades about what they want to see in screening is important. Because we know these tests are blood tests, and less invasive tests are going to be the most important driver of screening uptake if they are paid for and available.
Yeah, I would just add also that the challenge, I completely understand the value of seeing, like, you know, a one-stop shop for cancer screening, but the issue or the concern is that the follow-up is cancer specific. So just to go back to a portion of your talk where you indicated you would not, you know, opt to use a lung cancer screening test on a 30-year-old never smoker because the value of that test in that person or that population does not outweigh the risks of the false positives in that population. So and the same thing has been explored across different cancers for different settings. For example, in the ovarian cancer community, you know, we have a number of really wonderful monitoring analytes, but they have been prescriptively referred, the clinical community has said they should not be used as screening tests. But if those tests that the clinical community has come out and said these should not be used as screening tests perform better than the multi-cancer detection test, shouldn't that be really part of the information that a physician has when making this decision to follow up? So that's why I think it's really important, because even though you can look at it from a broad cancer perspective in terms of detection, the risks of the follow-up are all unique to the result.
So I think, but the risk that I was most concerned about with the low-dose CT is not of the false positive, it's the screen itself. To expose all those people to the radiation of a low-dose CT when you're going to find virtually no cancers. The sensitivity is probably the same. The specificity may be the same, but the yield is going to be really low, and you're going to be exposing tens of thousands of people to the radiation of a low-dose CT scan to find one lung cancer. So it's not that I'm worried about a few people being referred to surgery, because the specificity is probably the PPV is probably very similar, so it's going to be really rare. The problem is that you're not thinking about what proportion of the people you screen are actually going to benefit. And with ovarian screening, we know that we don't have a good test for ovarian cancer to be used in screening. You know, the best things have been shown in at least 3 clinical trials not to work. And so it's not a question of who should be getting them. We do something to people who are really high genetic risk because we feel we've got to do something, but they end up getting screened every 4 months in the UK at least, until they have their ovaries removed because they've, are getting close enough to menopause that they're happy to have their ovaries removed. So it's not a sort of screening that anyone would recommend for the general population.
All right, well, thank you for that. I think disagreement is actually super helpful in the context of this discussion because it highlights how many things we have that are we disagree on and need to kind of come to some resolution on. Maybe some of them won't be resolved. Just reminding people to please put your comments in the chat if you have questions for the audience or for our panel. And the last question that we have kind of in our prepared list, and then would love to see if there's any last questions we could get from the group here. I feel like some of these statistics are even more confounded by the fact that we will soon have single cancer blood tests, multi-cancer blood tests that only do a panel of cancers, and then multi-cancer blood tests that, claim all cancers. And so how do we best help stakeholders understand the statistics around that, and what kind of context do we need to be thinking about providing as these tests all come out and add even potentially more confusion to the field?
Well, I would have nothing new to add, except again, that's where the value of being a little more granular is. Yeah.
I wonder, Jody, if you have anything from the patient perspective that you might.
The patient perspective is hard because it's such a departure for how we were thinking about performance metrics from the development side of things, because it is truly, does this work? Does my provider recommend this test? And what cancers does this or look for? the actual being able to navigate the individual performance, I would venture to say, and we could actually survey for this and probably should, when we ask about performance metrics, be it sensitivity, specificity, PPV, NPV for a mammogram to people with breasts across the country, what their knowledge is of those performance statistics. Because I will tell you that when the huge volumes of women come back with needing a diagnostic mammogram, they surely do not know that that is not an uncommon thing. So, and these tests have been around, that mammogram's been around forever. So, I think we just have to be very conscientious when we're talking to the patient populations that they're going to be getting the recommendation from their provider.
I want to add, obviously with a game changer like the MSED tests, and the performance issues being what they are across different cancers and the different follow-up, you really are looking at a test that really requires very interactive physician-patient engagement. And so, it's like, why do people buy lottery tickets when there's only 1 in 171 million chance? Because the winning is just it would be incredible. And it's almost like the flip of this with the MSED. The stakes are so high. Why would anyone turn this test down? Why would anyone not go forward with this test and pursue out of a fear that they may have cancer and this test could be life-saving or life-changing? But so the information and how each patient is going to respond to the test result is what's really where BLOODPAC and the stakeholders have to be looking at so they can understand what the process is going to be. And very specifically, who is accountable for taking that patient through that process, because they need to understand what that process is going to look like.
Great. Thank you so
I think
much.
it's going to be
Go.
really. Sorry, it's okay.
Yeah, go.
Yeah, so I think it's going to be really interesting because I don't think we've really had very much competition in the cancer screening world before. So the patients or the public do not choose what HPV test to get or what scanner to be used for their mammography. It's whatever their provider is providing. And it becomes a little bit like drugs. There are a choice of drugs, and you're relying on your physician to tell you which drug they think is best for you. And we probably need to accept that very often, if you went to a different clinician, they would recommend a different drug. And I think a difficulty is that I see screening as a public health activity, which means that it shouldn't require a 20-minute consultation with a physician to decide whether or not to be screened. That then becomes very difficult if you want to discuss all the subtleties that Donna wants discussed. But in a way, that then increases the cost of screening substantially and isn't clear that that makes sense from a public health perspective. It also, I think, will increase inequalities in the delivery of the screening, because the well-educated, middle-class, wealthy people will be able to get that consultation, and a lot of people won't, or they won't be able to understand the subtleties that the physician is trying to explain. So I think we really need to start looking, once you have several different multi-cancer screening tests, all of which work but cover a different spectrum of cancers, how we're going to manage that. So I agree, it's a big challenge.
Yeah, I just want to correct, I was not saying that this should be before the test. I was saying, no, because I was saying nobody's going to turn down the test. Who would? That's just so risky. You would hate to have that. It's after you get the test result.
But if there are 5 different tests available on the market, how should people decide which one to have? Or do we recommend that they circulate so you have a different one each year?
I would like to say that was going to be a physician-based decision, right? But it will, based on the way that physicians are operated now under large corporate structures, it'll probably be based on the corporate decision of the insurer. Yeah. So really, you're talking about how do you convince insurers to choose your test?
All right, I was going to give Bob Smith, I was going to go against Lauren's rules. Sorry, Lauren, and ask Bob if he wanted to unmute and talk about kind of how conventional metrics are ingrained in a little bit more about his comment. I'm not sure if he's still on though. Did he? Oh, there you are.
Yeah, I'm here.
All right, great.
Well, we heard this in meetings. I mean, you hear people commonly sort of descending into the same sorts of statements that they can be made everywhere, and they've made for the past 10 or 12 years. I mean, at our national meetings, where people say we have to be very concerned about the false positive rate. Well, have they been reading about these tests? The false positive rate is really, really low. And you have to ask yourself, is it really a false positive rate if it correctly identified a signal, but you can't identify the cancer? Actually swapping out the false positive rate for the recall rate makes a whole lot of sense in a continuum of screening. It just means that you have to get more information to determine whether or not the patient has cancer. I think the other thing about these tests that we have to be really, really clear about is, and everybody who works with them is making this point, if the test is a test to detect a multitude of cancers and reduce the incidence rate of advanced cancers, you do, of course, want to know how they perform for individual cancers, but the larger issue is how they perform in terms of reducing the incidence rate of advanced cancer. And over time, they're likely to evolve. We're likely to understand new treatments are likely to evolve and all that. But any reduction in advanced cancer is probably going to be advantageous. To the point that you pick them apart and then justify and evaluate the whole test on the basis of one cancer for which it's not, delivering a majority of localized disease just doesn't make a whole lot of sense. So one of the things that comes to mind is the practical thing. How do you start promoting these new ways of thinking collectively so that they get more visibility? And so the logic of using these new metrics begins to make more sense. And I'm wondering if, Peter, if you have any thoughts about that. Are there ways that you can really promote side-by-side comparisons of these metrics with new data or even previous data? And so in new ways of actually thinking about how we evaluate screening. And just to add to that, how we evaluate screening in terms of the real, frankly, impossible way that we have an alternative to reduce 2/3 of cancer deaths that are accounted for in these cancers for which we don't have single screening strategies.
I think there's a big challenge. It may help to illustrate the different metrics on existing screening tests and on existing tests which have not been adopted for screening, and show how actually this would help you to understand those things. I think ultimately you probably need to do some health economic modeling, and that, I assume, is what helps to determine whether the insurance companies or whether various national guidelines want to recommend screening. But these metrics are there to provide some sort of easier to understand and simpler early measures, both for the developers of the test and for the public to understand, because I don't think the public want to know that this is the exact cost per QALYs that comes from participating in this screening. But exactly, what does the patient want to know? And I think having something about, if I participate in screening, how likely I am to benefit if I comply with this recommendation to go and have an upper GI endoscopy because of a suspected screen that suggests I have an upper GI cancer. How likely is it to find that? I think those things are probably important for patients. But we should also realize that not every screen-detected cancer is a benefit. You know, some of the very early ones will be overdiagnosed. Some of the ones that are found at stage 1 and cured would have been found at stage 2 and cured with very similar treatment a year or so later. And some of the stage 3 cancers that are screen detected will still be fatal. So, you know, we do need to do the randomized controlled trials to demonstrate what the actual benefit of screening is. But I think, you know, the FDA is making decisions based on clinical validity, not clinical utility. And so we want metrics that reflect that as well.
Well, thank you, Peter. I think you get the last word. We are unfortunately out of time. I know there were a lot of questions in the chat that we did not get to. Appreciate people commenting there. I really want to thank our panelists and our speaker for this webinar and for the audience for participating. We hope to continue this discussion in other forums, so please watch out for that. Lauren, anything you need to say to take us away?
No, thank you all for joining. We will keep you guys posted on any future seminars we have and any AACR sessions or any other meetings that we host. And please feel free to always call, email, or text us. We're around for your input. Thank you, guys.
Thanks,
Everyone, have a great day.
Take care.
Bye.